Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Let's remember our famous saying, caring and sharing. Go to our website, www.medmoments.com. and email me. I so appreciate all the emails that are coming in about your medical illnesses, about what you'd like to hear about on the show. We need to hear that. And we need that focus such that I can understand what you're going through so that we can help others with their medical problems. We have another great show for you. Tonight we're going to talk about hip fractures and osteoporosis. I know it's a big word, but we're going to break it down, and I have an expert in the field to talk to us tonight. His name is Dr. James Lee Jr. He's an orthopedic surgeon. Dr. Lee, welcome to our show.
Thank you, Dr. Bey. Appreciate it. I'm glad to be here tonight.
Oh, I'm so glad to have you. Listen, I'm going to start off with my number one question, and I ask everybody the same question. What is a hip fracture, and how does it come about? And how does it, come about, and how does a patient get, their hip broken or hip fractured? Tell me about this.
Sure, that's a great question. A hip fracture is basically a broken thigh bone at the very top of the bone. Let me demonstrate here with a model. This is a thigh bone. We call it the femur bone. And when somebody breaks their hip, typically it breaks at the top part. This part here, the junction, we call that the neck, or sometimes below in this area. Why does it happen? Most of the time it's from weak bone. It can also happen from car accidents, falls from height. In our elderly population, older people, it's most commonly just typical falls, and that's from weak bone. And what usually happens is the patient or person falls and they can't get up, and they realize something's not right. I can't move, I have pain, and they'll say, I have pain in my groin area, and sometimes they'll feel it even in their knee, because the thigh bone and knee bone are connected. So oftentimes it'll be a fall, pain, and then say, I've fallen, I can't get up, that famous saying that we've heard before.
Oh yeah. Now, this usually happens to older patients, or can it happen to young people as well?
That's a great question. Younger patients, it's usually from car accidents, motor vehicle accidents, motorcycle accidents. We call this the high energy trauma, velocity, speed. Older folks, it tends to be from simple falls, less trauma. Weaker bone, so it takes less force to break the bone, and that's what usually happens with our older population.
Oh, all righty. So as we get older, our bones naturally get weaker or thinner or whatever. We don't have, it's not because I didn't eat right, or I didn't get up that morning at 7 o'clock, I got up at 6:30, so now I got thin bones. It normally happens?
You know what, that's a great question. I like to think about it as a bank, right? So in the bank, we have all this calcium stored in really solid bone when we're young, in our 20s and 30s. But after actually age about 30, 35, imagine withdrawing that calcium out of the bank, and we're not putting it in. So what happens is we're not eating the right way, smoking, drinking. So imagine we're withdrawing calcium out of our calcium bank, not putting it in, and that's a natural progression as we age. So think about that. You're basically losing bone because we're not putting that calcium and important nutrients in the bank.
All right. So now, I don't like you already. You know why? Because you just said, okay, not eating right, so I can't go to McDonald's now. And you said, I can't party, I can't drink. You're cutting my activities out here, you know what I mean? But I understand what you're saying. Basically, you're saying that you can't overdo certain things because it really aggravates as far as the bone is concerned, and it pulls that nutrient out of the bone.
Right. I think that's a great question. I think anything in moderation is okay. Naturally with our patients, we try to cut down on the smoking and drinking, but in excess, it's not good for you. Also, unfortunately, our patients who are on steroids, the new medication for anti-inflammatory conditions can also bring that bank or that calcium level down, so that the bone quality is thinner and more like a sponge and thin on the inside.
Now, there are so many patients that take steroids, though, and steroids they decrease inflammation, decrease swelling. That's the biggest thing that they do. But there's so many patients, asthmatic patients, patients with lupus, patients with arthritis. I mean, goodness gracious, there's so many patients on steroids.
That's right.
And that's one of the major contributors, huh?
It is. Believe it or not, it is. What we have to do is be safe. So if you're on steroids or any special medications that may drop your calcium levels or cause this osteoporosis, we've got to fill the bank up. We have to be on calcium and vitamin D. The vitamin D helps us absorb the calcium, so that's why we're on it together. But I think you're right. These are what we call, the risk factors. And unfortunately, some of our patients, because of the other medical conditions they have these risk factors.
Oh, goodness. Now, talking about risk factors, now, are females more apt to get this problem, to have this problem, than males? Is that? Do you see that?
Yes. Yeah. That is a great point. I think you think about just bone storage. Okay. Think about that bank model. I think men tend to have a little bit more in the bank, a little more volume of bone, and their storage is a little bit more. Our female population, you go through menopause as they get older, and in the Caucasian population, females, they're actually the #1 risk for osteoporosis, just because of that bone storage issue, and possibly not getting in the sun as much, and basically not allowing that bone to be healthy and absorbing that vitamin D and calcium.
Okay, alrighty. Now, the thing of it is that you mentioned the word that I started off with, called osteoporosis. Boy, I love medical words. Let me say it again. Osteoporosis. I like that one. What I want you to do is break that down for me. I know that is one of the main contributors to someone having a hip fracture or a fracture of a bone. Tell me about osteoporosis a little bit. What exactly is it?
Okay, so if we break that word down, osteoporosis, porosis is like porous or sponge, right?
Okay.
Osteo means bone, so basically spongy bone. And if you look at the bone under a microscope or something, you'll find that it actually has more holes in it, and it's thinner. It looks just like a sponge, but imagine that sponge has more holes and less of the actual fiber of the sponge itself, and it's more porous, and makes it a lot weaker.
Oh, alrighty. Now, can you get osteoporosis or these fractures in any other part of the body? Now, is it just the hip, or can it be other places like the spine, or another place that you can get fractures as well?
That's a great point. Yes, you can. Yes, you can. We all have seen the little old lady hunched over like this, walking down the street. That is in the neck. Okay, we call it the vertebra, but it's in the neck. It's back in here in these bones, and those bones actually shrink, and they cause people to lean over this way. The wrist as well. The wrist as well. Think of that, falling on an outstretched hand, falling backwards to brace ourselves. These are two other big areas where we're at risk for osteoporosis-related cracks, fractures. Oftentimes my patients say, is a fracture the same as a break? Yes, it is. They're the same thing. So, yeah.
All right then. Now, we're not talking about the fracture itself, but the osteoporosis part of it, is that different as far as race is concerned?
It actually is. It actually is. I mentioned before, Caucasian females are the #1 risk population for osteoporosis.
Okay.
Not as common in the African American population, but it still is there.
Right.
But there is a difference, yes.
All righty. Now, do you ever find young people with osteoporosis? I mean, their bones are thin for some reason or other.
I have. I have. Most of the time on the younger population, severely malnourished. It can happen. Again, our patients on steroids, patients on other medications where maybe it affects their bowel or ability to absorb those nutrients, so they actually lose that bone storage and that calcium drops down.
Okay. Family history. If I have a mom with osteoporosis and I'm a young female, what should I think about? Can it happen to me?
Yes, it can. I think, if you have a relative, mom, grandmother, it's certainly a risk factor. Think about the diet. Are you getting enough calcium? Are you getting enough vitamin D? Are you exercising? Okay.
All right.
It's an important thing when we think about this spongy bone. believe it or not, walking, exercising, bone responds to weight bearing, walking, doing these activities actually makes more bone. It stimulates the body to actually make more bone. So if you're able to be active on top of making sure that you have enough calcium, vitamin D, and other nutrients in your diet, it will help a lot.
Oh, interesting. Now, we've been talking about women. Women, well, we got to give the men their share of this. Now, can men have osteoporosis, or are we just stronger, in nature and it doesn't happen to us?
Absolutely, men can get osteoporosis. Same risk factors, dietary needs. We certainly are at risk. We have to have the same level of calcium and vitamin D in our diet. A lot of times, I'll discuss this with a family in a room, and I try to address everybody, men and women, to say, listen, we all of us need to be on some type of a supplementation, or at least get the daily minimum of vitamin D and calcium, or else we're at risk as well.
Now, I was reading something, and they said something about testosterone. If men have decreased testosterone, I know that the low T syndrome is all over the TV set now, but does that lead to osteoporosis? So we have to replace the testosterone to make our bones thicker?
No, typically not. Testosterone is it can deal with energy and muscle building, but not as much in bone building. It's more or less the diet and the low calcium and vitamin D that's more important with that.
Okay, yes. Okay. Now, as far as the osteoporosis, I haven't fractured my hip yet, but as far as how do I know I have it? I mean, is there a symptom? Do I get nauseous? Do I get, is there any way that I could figure out I have this thing?
That's a great question. Yes, you can. I think typically in the elderly population, or maybe over 55 years of age, we do a bone density study.
Oh.
Okay, it can be as simple as a hip X-ray, where you can look at the bony architecture, or more of a screening test, and we call that a bone density study, where you can get that at your primary care office, at a hospital, even at the orthopedic doctor's office as well. You can get this study, and it'll actually calculate your bone quality, more or less.
Okay. Now, what about treatment? As far as giving some of this calcium back, if I go to the drugstore and I get calcium pills, will that help?
It can. As we get a little older, there's a daily minimum requirement. I'll say about 1,200 milligrams or so over 55 of calcium. There are these tablets that actually are a combination of vitamin D and calcium. Just to name some, Ozcal, Citracal, over-the-counter medications, and typically it's 1 or 2 tablets a day, and it gives you your requirement for vitamin D and calcium.
Now, why do you need the vitamin D? Does that give the calcium a kick, or the calcium needs the vitamin D to work, or what happens? Why do we have to add that to it?
All right, so yeah, that's a great question. So as we ingest the calcium, the vitamin D actually works on our stomach or our gut to help absorb the calcium. All right, so it works on our our intestines, our gut on the inside. And if you don't have that vitamin D, you can take all the calcium you want, you really won't absorb as much as you should.
Oh, all right. So I think that was a good explanation of what osteoporosis is about. What I'd like to do is I'd like to go back to our talk about the fractures of the bones and what we can do about them. When someone fractures a bone, how do they present? Do they use it? Can they walk into your office, or usually are they all coming through the emergency room, or how do you know you got a fracture? Is it just a little pain, and you said the growing pain, or how am I going to present to you?
That's a great question. Most patients, I would say most, present on the ground. They actually fall down, and when I see them in the emergency room setting, they're usually in a stretcher or a bed, and they can't get up. They'll be with their family and just say, I can't get up. And they just feel pain, a sharp pain. It's in the groin. A lot of times, you look at their leg and it's turned to the side. Oh, it's turned to the side because the hip actually controls the motion, and when it's detached through a break, it no longer controls it, and the hip actually rotates out to the side. And so you look at their feet. They'll say one will be like this and one will be like this, because that bone is actually broken. And you'll say, wow, something's not right. And then my foot points out to the side. So that can be something that you see commonly.
All righty. Now, does everybody need surgery? Are there some people that can have a fracture and not need surgery, or other people need surgery? How does all that play together?
Okay.
Come together.
All right. So most patients, if that fracture causes them to fall down and they can't walk, they most commonly will need surgery. Not every hip fracture needs surgery.
Oh.
What I'll say is this. I can hopefully demonstrate on this model again. If you look here, we talk about the top of the bone. We call that the head, the neck. And then here we call this is the trochanter or side bone. If you have a small crack through here, chances are you don't need surgery, okay? Because the head and neck are still working, so you can probably walk. The problem happens is if you crack the head part, this part, or the neck, you can't support your weight. Okay, with this crack, you can still support your weight, your body weight, but if you crack through here or in a special part of your hip, you cannot support your body weight, and then you need help. You need something that will allow you to support the weight, and that's where surgery comes in. So we can say, all right, listen, you broke a special part of the bone, and if you break the top part, like almost like we saw, like an ice cream cone on top. Unfortunately, when you break this part, the blood flow to this area sometimes isn't very good and has to be replaced. Okay. If you break further down, more in the bone part, we can try to fix it because we have two really good pieces of bone to come together that we can bring together.
Right.
All right. So oftentimes the location of the fracture will dictate how we treat it.
Okay, so step back for a minute because that was great. That was a great explanation. Now, when you said that if the blood flow does not come back to that head, what do? Do you put a false head in there, or how do you do that? I mean, how do you get that blood flow back so that it will heal naturally? What can we do?
Okay, so if this part, the ice cream cone, if you will, has been cracked, the blood supply often is so bad that it cannot be fixed. Okay, especially in an older population, it just, what we have found is if we tried to fix this, it falls apart because the bone no longer has the nutrients that it needs to heal. So what we end up doing is like a replacement or a partial where we actually remove the damaged bone and we put a rod down the thigh so that the patient can get up and walk right away. That's why it's made of these metals like stainless steel and cobalt chrome, and we actually sometimes will put cement to help hold it in place. So we get people walking the next day, and it's really, really strong. So it replaces what they have, gives them something even stronger than what they have. So we get them out of bed the next day.
Go on.
Yeah.
I like that. Yeah. I like that. So you mean if a person fractures their hip, the bone is broken, you go in, put a new piece of hardware in there, a new head, and put the rod in, or however you explained it, and I'm up and walking the next day?
Believe it or not, yes. That is our goal. What we have found is that if we don't get you up walking within a couple of days, we get things like urinary infections, pneumonias, blood clots, because we're not walking. And believe it or not, our muscle tone drops down. After even 24 hours in bed, muscle tone drops, and we get weaker. So if we don't get our patients out of bed and try to get them moving, what we found is they run into these other problems, and we get worried because then you're really, really battling uphill. If somebody isn't out of bed, they suddenly have a blood clot. That's why they're in the hospital longer, like 4 or 5, 6 days. Why is grandma out and still in the hospital? Well, they have these other problems, and that's the issue that we face.
Alrighty. Now, we know that the patients in the ER, they probably have a hip fracture because their leg is going out that way. What tests do you do? Do you do x-rays to find out what do you actually do to find out where this problem is, or if that's the real problem?
That's a great question. X-rays for sure. We always do a good exam on the patient. So you can even go in the room and see, like you said, the legs out to the side, and we get a good history, and we say, all right, what happened? What do we need to do next? And we do that X-ray. We do an X-ray of usually the pelvis, so we can see both hips and compare the two. And we'll also usually get a thigh X-ray to make sure that crack didn't go all the way down to the knee, because that can sometimes change what we do. If the crack stays up here, usually we just stay up here. But if it goes all the way down, say if the patient had a prior replacement or has prior, metal in place, we have to make sure that metal is okay and that the crack didn't go all the way down the thigh bone.
Oh boy, that could be pretty dramatic. Goodness gracious. Now, what about as far as like if you somebody was telling me about bone scans? If you can't really see the crack, then maybe tell me, what is a bone scan? Okay, I heard of this one.
That's great. So a bone scan is a study where we can look at the entire skeleton and we can look to see if there is a crack or what we call bone turnover or bone activity. Okay, so when you crack a bone, your body tries to make new bone, and if we're able to see the body putting new bone or trying to heal an area that has been injured, we can say, all right, you know, there's a little crack there because the body is basically like, it's almost like a Christmas tree lighting up, and it lights up right in that problem area.
Right in that area, so you know exactly where to go.
Exactly.
It's like a road map. Right there, that's the problem.
Right, exactly.
It's like some of my patients, they come in and say, Doc, I got a pain right here. I said, oh my goodness, when you touch right there, yeah. I said, just don't touch that. You know, just don't, you know, I understand what you're talking about. So right there. Okay, tell me about, I know you've gone to, you've diagnosed it, you've taken the person to surgery. What complications can happen after surgery? I mean, you're talking about elderly people. You're talking about people that, you know, obviously they have poor nutrition. Obviously they maybe have lost weight, or they don't eat right, and not because they don't want to, it's just because they maybe not able to, or, you know, for whatever reason it is. What are some of the complications that you can see because of the hip fracture? Do people do they lose the ability of walking sometime, or do they forever have weakness in that area? Tell me about that.
Yeah, that's a great point, a great question. What I found, I try to tell my patients, say, listen, you know, if you're you know, in your 80s, you break your hip, and you know, you were walking in the community with a cane, you know, maybe when you're done after having your surgery, you might walk with a walker. Or if you were walking independently and you broke your hip and we fixed it, you know, there's a small chance you might need to use a cane. So what we find is that you can have changes in the way you walk, maybe sometimes a little bit of a limp. Sometimes the patient can develop arthritis afterwards because you've cracked next to a joint. Right, so these are some of the other issues that can happen. On the orthopedic side, on the medical side, you know, we talked about a little bit, you know, before. You know, if you develop a blood clot, you know, we put our patients on blood thinners because they're at risk. They just had surgery. They broke a bone.
Tell me about this. You say a blood clot, but were you talking clot in the tissue, or is it clot in the vessel, or what are you talking about, a blood clot?
Blood clot, okay, so usually it's in a deep vein in the leg. That's most common.
All right,
okay,
deep vein. All right. You're throwing out these terms here now. So there are not deep veins and some deep veins. You know, tell me exactly, these are the veins that are really inside your leg, deep inside your leg?
They're like by your calf muscle.
Okay, so these are the larger veins, or the small?
Yeah, well, you can get either one, but a lot of times it can be a larger vessel that has a clot that forms. And what happens is you're from not moving around and staying in one place, having surgery, the blood sort of pools in the area and it stays in that one area, and then unfortunately the body's response is to clot. You just had a surgery, so I need to clot. I need to fix this. Yeah, and that's what happens with the blood clot. Okay,
now as far as a prevention, you know what I mean? Is there certain things that an elderly person should do to try to prevent it? I know of the calcium, but should they be mindful? I mean, like, patients have vision problems and, you know, things like that. I mean, what do we tell our patients to try to keep this from happening to them? Because we know that the elderly populations, they're vulnerable to this particular problem.
Well, that's a great point. I think home safety. Home safety, making sure you almost have a plan in your house, knowing where the stairs are, not a lot of clutter around your couches and your furniture. Making sure that there's a support system available around the household. Basically, small minor things that you can do to make sure that your house is safe. You can even, you know, have somebody visit your house and look at it and say, listen, you know, I think you need to rearrange where your TV is or your couch is in an area that's close to the door that might put you at risk for falling down. Also, we talk about exercise. If you can exercise, even if you can't walk a mile or two, you know, walk around the block. You know, 2 to 3 days of just walking around stimulates that body to make bone, and that can also help prevent fractures too.
Okay. What about stairs? I know, because I'm always fearful of stairs, you know what I mean? That you're gonna fall, or if I'm running down the stair, I misstep or something like that, tell people to, you know, watch it or take their time, and especially if you have stairs at home.
Yes. Make sure that you take your time going up and down stairs. It's well lit. Don't, you know, if you have slippers or, you know, make sure that you have some traction underneath or some good socks, so that when you do take that step on the stair, you're not falling out, making sure there's no water or a mess or any type of clutter, because you're right, you know, one false move and you know, it could be a problem.
Okay. Dr. Lee, This has been an excellent, excellent interview. I'm so happy you came in to talk to us about hip fracture and osteoporosis. Thank you very much.
You're very welcome, Dr. Bey. Thank you for having me.
Thank you, thank you, thank you. It's time. It's time that we talk about we just need to talk about something. Let's talk segment. And what we're going to talk about today, let me flip my little pages here because I want to get to it. We're going to talk about cholesterol. And there are several types of cholesterol, okay? There's the LDL, which is the bad cholesterol, and there is the HDL, which is the good cholesterol. And when we talk about the bad cholesterol, we're talking about that cholesterol that clogs up the vessels, and that cholesterol that may cause you to increase the chance of having a heart attack. And that's what we want to prevent. We want to prevent those heart attacks. So what you need to do, if you think you may even have elevated cholesterol because you've been going to McDonald's too much, what I want you to do is go to your doctor and ask him to do a cholesterol level. And if that cholesterol level is above 200, then he has things that he can give you, medications that he can give you, things like, and suggest exercise and a better diet so that we can better keep that cholesterol in a better level so that you won't have that heart attack. I don't want you to have that one. All righty. What I'd like to talk about as far as in closing, remember, never institute any change in your medical therapy. Okay. Never institute any change in your medical therapy until you see your doctor, okay? And as far as sharing and caring, please call me. Go to the internet, www.medmoments.com. Give me your information about how you're doing and all of that so we can do a better job on the show. Remember, I'm Dr. Omar Bey. And this is A Moment in Medicine. Until next time, I want to say peace to you all. Dr. Lee, thank you for coming in.
Thank you, Dr. Bey.
Thank you. It was an excellent, excellent interview.
Thank you very much.
And we're going to have to get you back in so that we can do another topic.
I'd love to come back. Thank you for having me.